Good afternoon, everyone. My topic is on DNA-directed RNA polymerase inhibitors, and the only drugs under this is rifampin. It's also known as rifampicin. So it was discovered in 1965, and it was first marketed in Italy, 1967, and then in America, 1971. So it acts both on gram-negative and positive. It's a broad spectrum and it's the first line of anti-tuberculosis drugs. So it can be used alone or it can also be used in a combination, but it's preferred to be used as a combination because if you use it alone, it has bacterial resistance. So it's best to use with a combination. So the mechanism of action is it inhibits bacterial DNA-dependent RNA synthesis by inhibiting bacterial DNA-dependent RNA polymerase. Then it binds to the polymerase subunits with RNA DNA channels. Then leads to blocking of the RNA chains and decreases the affinity RNA polymerase for short RNA transcripts. So here it can be bactericidal or bacteriostatic depending on the organisms it's acting upon. The available doses are 150 mg, 300 mg for capsules, tablets, and for IV, 600 mg. So pharmacokinetics is it's well absorbed in the GIT tract and has 80% protein bond, plasma protein bond, and the half-life is 3 to 4 hours. And it's metabolized in the liver, so you have to be watchful because it leads to hepatotoxicity. So the available drugs in our hospitals are this: rifampin syrup, 100 mg to 200 ml, rifampin 450 mg plus isoniazid 300 mg tablets, a combination, rifampin 600 mg plus isoniazid 300 mg tablets, and rifampin 150 mg capsules. So here, for tuberculosis, it's the course of treatment runs for like 6 months, and for other bacteria, maybe 4 days, depending on how severe it is. And daily wise, it shouldn't exceed more than 600 mg. So the indication is for tuberculosis, leprosy, staphylococcus, and selected gram-negative organisms. And the dose is 10 mg for tuberculosis, 10 mg per kg per day oral, or 10 mg per kg oral twice weekly. Then for hemophilia, 600 mg per day oral or IV for 4 days. So there are different drug interactions here. For atorvastatin, it increases the toxicity of this drug. And for silodicin, quinidine, methadone, it decreases the level of the drugs. So, and the LFT should be monitored due to the hepatotoxicity. And for contraindications, it's contraindicated in a lot of drugs like HIV, protease inhibitors, typhoid vaccines, BCG vaccines. For HIV protease inhibitors, basically what it does is it decreases the effect of the antiviral drugs and makes it to have resistance, like the resistance becomes more or no effects at all. Now, why for typhoid vaccines or BCG, it decreases the activities basically. Then for dosage adjustments, for renal, there's no dose adjustment, hepatic, no dose adjustment, just basically you have to monitor the patients. And for geriatric patients, it has been recorded to cause esophagitis, which is like increased acid in the lungs. So it's advised to take with a full glass of water 1 to 2 hours after meal or before meal. Then the adverse effects, we have both dose-dependent and dose-independent adverse effects. For dose-dependent, you have discoloration of the urine, feces, saliva, tears. Basically, it turns it into red or reddish orange. Then it causes thrombocytopenia, hemolysis, and hemolysis. That's all. So side notes here is that rifampin has been monitored to cause a lot of bacterial resistance due to mutations, leading to a change in the structure of the beta subunits of the RNA polymerase. So that's it for that drugs.